Welcome everyone who's joining. We will get started in just a moment. Elena, do you want to let me know when we start to slow down in terms of folks joining?
Absolutely. I think we can just take a few more seconds and then get started.
Sure.
All right, Allison, I think we're good to go.
Great. Thank you so much. Welcome, everyone. We're so excited about this workshop. I'm Allison Hamilton. I lead the UCLA Rapid, Rigorous, Relevant Implementation Science Hub, which is part of CHIPS at UCLA. And this is a co-hosted session with our fellow Implementation Science Hub at the University of Washington. You'll hear more about that in a moment. Our methods workshop today is about implementation cost analysis, and we are absolutely thrilled to have Drs. Russ Glasgow and Carol Levin do our presentation today. You'll hear a bit more about them in just a moment. If we could go to the next slide. So just to give you a quick overview of these hubs, as I mentioned, these are two hubs represented here on today's session. Based at UCLA and University of Washington. These hubs are funded by NIH to support a variety of supplement projects that are all oriented toward ending the HIV epidemic. So we have a network of, I think it's 9 hubs now, and we provide consultation, coaching, implementation science expertise to these supplement projects, and we also provide a number of different workshops and other types of knowledge activities that are aimed toward enhancing the implementation science knowledge base. So I'm very honored to lead one of these, and I'm very, very thrilled that the University of Washington and our hub were able to co-host today's session, which is a topic of great need in the field. Next slide. So yes, I noticed in the chat, this session is being recorded and it will be available in multiple places. So don't worry if you have colleagues who wanted to be here but weren't able to be here. We will be posting the recording both on the UCLA YouTube playlist, and Dr. Scher will share a little bit more about his hub as well. You can feel free to contact our hub at the email you see here. And now I will turn it over to Dr. Scher for a little bit about his hub.
Great, thank you, Allison. So I'm Kenneth Scher. I'm a professor in the Department of Global Health at the University of Washington, and the RAISE IS Hub, or the Research Alliance for Implementation Science for Ending the HIV Epidemic Implementation Science Hub, is funded through the University of Washington and Fred Hutch Center for AIDS Research, and is specifically part of the Implementation Science Core at our CFAR here at the University of Washington. And like all hubs, we focus on providing technical support for EHE-funded implementation research projects. But our particular focus is trying to improve or integrate implementation research into health department activities across EHE jurisdictions. And as Allison mentioned, we also have a webpage where you can contact us, and a YouTube channel where we collate all of the webinars that we've been hosting as part of this hub. And feel free to reach out to us at the email listed on the slide. And just to note, if you're interested in attending more webinars supported by RAISE, our next webinar will be on time motion studies, and that will be held on Thursday, October 26th at 11 a.m. Pacific time, or 2 p.m. Eastern time. Next slide. So today we have two fabulous speakers who are going to be going deep into implementation cost analysis. We're going to start with Carol Levin, who is a professor here at the University of Washington in the Department of Global Health. Carol comes with decades of experience in developing costing methods, originally coming out of the agrarian economic space and then moving into the health economic space, and has applied these methods in a variety of settings, both domestically and globally, as well as across a number of different research or domain areas, from mental health to reproductive health, and now germane for today's talk for HIV and AIDS prevention care and treatment space. And so we're delighted. Carol's going to lead us off. She's going to talk about some of the methods that she's been developing and applying, focusing on capturing costs of implementation strategies, and then we're also then going to move on to have Dr. Russ Glasgow join us and to give a talk around some of the work that he's been engaged with in applying these methods, largely in the domestic space. You may have heard of Dr. Glasgow. He is a research professor at the Department of Family Medicine at the University of Colorado in Denver. Russ has been a leader in the space of implementation science since its inception, working out of initially the NIH, where he coordinated and really led spearheaded the Trans Institute work group on implementation dissemination science. You may also have heard of Dr. Glasgow, as he was one of the main innovators of the RE-AIM framework, which is a well-known and applied summative evaluation framework, but it really has been a huge influence on the fields in terms of spearheading novel research in implementation science, developing new methods and applying these methods across a variety of settings. And so with that, we're going to turn it over to Carol, who's going to lead us off and talk about some of her implementation cost capturing methods. Thank you so much for joining us.
Thank you, Kenny, for that introduction. And while I get my slides up, just want to, we do have a poll. That's right. Over to actually Elena first. Go ahead, Elena.
Thank you. Thank you. We're just going to do a quick poll here before we move into the presentations. So the question is, have you ever conducted your own costing or cost effectiveness analyses as part of your research? And we'll give folks a few seconds to answer yes or no. All right, looks like we have responses from most folks on the line. And here are our results. So it looks like 32% say yes and 68% say no. So some of this should be new to a lot of folks in the room.
Great. Okay. Good morning, good afternoon, good evening, everyone. It is a pleasure to be here. Dr. Glasgow and I have a lot of material. I want to let you know that the slides will be available. And we're really excited to convert many of you who have never done any costing into costing. And I want to say that in developing this webinar, Russ and I could talk for hours. All right. We have a lot of shared experiences. We come at this with a very pragmatic approach.
Dr. Levin, I'm sorry to interrupt you, but it looks like your presenter mode is showing. So
okay, how's that?
Yeah, that looks great.
That is strange. I'd rather it be the other way. Okay, that's what it is. Okay, so as I was saying, just want to give all of you who have never done costing, I want to let you know that I came at this as an agricultural economist and had to learn it. So I like to tell people, if I could learn it, so can you. So today, I just want to let you know that we have two parts. We want to build in question and answer and discussion. So I'll let you review the learning objectives, but I plan to set the stage with a basic primer on costing, regardless whether it's interventions or implementation strategies. These are the basic principles of costing. And then and then we'll have a discussion, and Dr. Glasgow will start to raise some of these pragmatic issues when focused on implementation costing. We want to answer your questions, so please do ask them in the chat box. We'll have a facilitator who's collating those, and we'll raise them at the question and answer time. And we hope by the end of this webinar, you are familiar with some basic principles and more importantly, some of the pragmatic issues that occur when costing implementation research. My own presentation will focus on a little motivation. I was pleased to see we have so many people joining from around the country and maybe even outside of the country. I presume many of you are involved in implementation science research, so some motivation on how cost data are used and framing it within the implementation science research, basically a brief primer, agnostic to what you're costing, and time permitting, a case study from Zimbabwe looking at basically a supportive supervision for PMTCT. So let's get to the motivation. Typically, cost data are used for many purposes. Costing intervention is how I spent most of my career, but more recently, costing implementation strategies. And the outputs of these studies are typically financial or economic costs of interventions or strategies that are used to understand affordability or cost efficiency, financial projections, forecasting resource needs. But costs are really very important also for health economic evaluation. We are focusing today on the left-hand side of this slide, but keep in mind that the use of cost data informs how you collect it and how you analyze it. So cost is one piece of critical information for decision makers. Health economic evaluation that tells you whether it's good value for money or is used for priority setting, decision making, especially since we're all operating in with constrained budgets. So if we start to jump to cost, the rationale within implementation science, I know many of you are familiar with Proctor's model here, but you know there's also many different models with different structures and different taxonomy. I like this one because it highlights cost, an area where I've done a lot of work, even though I'm not an implementation science researcher per se. And in this taxonomy, costs typically refer to the intervention or implementation strategy. A review by Ariana Rubin-Means and co-authors noted that often they don't capture the cost associated with patient needs or either health system needs for scaling and sustainability. And we'll address those issues today. I found that when I was trying to understand the role of costing in implementation science, I came across this TCU program change, Texas Christian University, program model for planning and implementing innovative innovations for treatment typically for behavioral health. And resources and costs, you can see, underline all phases of the implementation process to reach practice improvement. I would argue, though, that actually when we cost, we have to incorporate the resources and costs associated with strategic planning, preparation. Otherwise, we're going to underestimate the costs to introduce and scale these. For many years in the field of HIV and AIDS, for instance, the focus was on costing the service, the testing, the treatment, neglecting those above facility costs of supervision, of system strengthening, and therefore underestimating the requirements to reach HIV prevention goals. So it's really important to consider strategic planning, training, materials development, laboratory materials, and any of those licensing fees, especially for implementation strategies. So today we're going to try to cover the basics of costing, some steps to simplify, and explore pragmatic aspects based on Russ and my years of experience. So let's get going with a brief primer. What are costs? So for those of you that are new to this, costs are simply a short way to describe the estimation of costing, producing the production of a health service typically, or a strategy, an implementation strategy. Costing places a value on the total resources used to produce a good or service. It requires measuring each resource and needs information on the price of each resource. Costs can vary by context, so it's important to gather information about the location, the time period, the population, and other factors that you think will affect the cost of the service. As this figure shows, the type of resources to produce a health service or strategy include human resources, and equipment. Drugs may not be relevant for implementation strategies, but certainly supplies and equipment would be. Now, there are different types of costs. You may have heard that I mentioned financial and economic costs earlier. These are important distinctions. Financial costs represent the actual expenditure on goods and services, and these costs are typically used for budgeting or financial cost projections, assessing affordability. Economic costs, however, are essential for using in full economic evaluations for understanding efficiency, allocative efficiency, technical efficiency. These are collected for use in modeling cost and cost effectiveness, and they include all resources used, whether they're valued or not, and sometimes whether they're provided, but they don't reflect the true market rate. So if you subsidize a good or service, or you use volunteer time, we aren't capturing the true value of that commodity. So financial economic costs are important terminology when considering costs. Now, from an economist perspective, we use these terms, and I'm going to briefly introduce them. And these are typically what's generated in cost studies. We can think of total costs, which represent the cost of producing a service or a strategy. So for instance, it could be the total cost of developing, deploying, and maintaining supportive supervision for HIV counseling. An average cost is simply taking that total cost and dividing it by some output. That output will depend on the focus of your study. It could be a site, a clinic, a client enrolled in health, HIV counseling and testing. The marginal cost and the incremental cost, these are two terms that typically get confused, not just by non-economists, by economists as well, who start to move into this world of costing and economic evaluation. Marginal cost is a concept that we use in economics to look at what is the cost of producing one more unit, right? So if I'm currently screening and testing for HIV, what is the cost of reaching one more client? Now, this is a very different concept than incremental cost, and incremental is very relevant to implementation science. Why? Because it's the cost of adding a new strategy to an existing intervention. We already know that HIV prevention and treatment is effective. However, it's not reaching the coverage, or it's not been adopted. We haven't met our targets. So what strategy is going to help us close that know-how gap? And that is an incremental cost of adding a new strategy to an existing intervention. So we have different kinds of cost categories. This again depends on the goals of your study. You may be interested to look at cost by inputs, by activities, by the level of service delivery, or timing. In the case of implementation strategies, you may be interested in the cost per implementation phase, and we're going to be exploring that in Dr. Glasgow's presentation. So let's look at some examples of what are typical input and activity categories that are relevant for both interventions and implementation strategies. These don't really change across intervention versus implementation. So we have personnel, equipment and capital costs, supplies, contracted services, travel and per diems are often important, and transportation. And similarly, it's sometimes more useful and easier to consider activities like planning, designing and developing materials. Training is a big part of much of the work we do. Procuring and installing a program, maintaining it, managing it, and supervising it. So these are the more standard you can get on these input and activity categories, the better we can compare costs across studies. Next, there's economists also are really concerned with distinguishing between fixed and variable costs. This is particularly important for scaling up. When we move from a randomized controlled trial a pilot or a demonstration project to a national or subnational program, we need to understand how costs vary between fixed and variable. So, simple rule, fixed costs basically remain the same no matter how many people you serve. Typically, we think of these as large items that are durable and last over a year. If you have had to buy a vehicle for a particular intervention, it doesn't matter how many clients you serve, you have one vehicle and it serves them all. Variable costs increase with the number of units, sites, or clients that receive the intervention. And these will vary depending on the scale of the implementation. A little secret for that economists like to say, in the long run, all costs are variable. Even when we scale and increase coverage, it may require additional investments in computers, in buildings, in vehicles. So in the long run, really all costs are variable. But using that terminology, what do we know? Here's some example of input categories that are fixed: vehicles, equipment, startup activities. Are often, this is a sort of little secret for many of us that do costing, those one-time activities that have to happen at the beginning of a project that only happen once, all that planning and designing of an intervention, developing materials, training, sensitization of your partners, whether it's schools or health centers or the community. These happen once and they can be treated like a fixed cost. The other variable costs are fairly standard. So once you have identified what your costs are, you need to quantify. Once you identify what your various inputs and your activities are, you need to quantify and value these. So this is the art of costing. The data collection methods are not too untypical of what you may be doing through process evaluations, but it does depend on the objectives of the study and what is your budget and timeline for data collection. So if we're looking at an existing program in a school or a health system or a strategy, if it's already in place, we may need to use a skill called microcosting, where you literally are trying to understand what are the activities, what are the resources, what are the inputs for each activity. You have to quantify and cost all of those inputs consumed for each activity. And you have to obtain price data. So that can be quite daunting and time intensive. If you're actually working with a program that's been funded by NIH and it's coming through your own organization, or it's funded by an NGO, which is often the case, certainly in global health, you might be able to use what's called gross costing. You might be able to use the financial expenditure records from the project, and you can use those data to get total and average costs. In reality, we use a mix of methods. So I mentioned that if you want to get from a total cost, remember the full cost of a program, and you want to get to a unit cost, an average cost, you're going to need some measure of outputs and outcomes for costing. So this can cause a lot of, I'm going to talk a little bit about some of the challenges that this happens in practice. But these data, outputs and outcomes, come from either your randomized controlled trial, in the case of implementation science, a hybrid research design, hybrid evaluation, hybrid effectiveness study, from ongoing monitoring or surveillance data. You might like to get outputs and outcomes at different levels of analysis, sites or clients. And again, we should all be thinking about enhancing comparability of our data. So standard outcomes and output units are helpful. So I'm going to ask you to think about what kinds of what are typical outcomes for implementation strategies. Feel free to type your response in the chat box. I'm going to move things along, tell you what I consider and what my experience has been on the implementation outcomes. This list is what's typically identified in NIH grants that I've worked on, and some of these are operational for using in costing studies, and some aren't so easy to operationalize. Penetration is one that has been easy to operationalize. It's often the number of clients reached, right? So it could be the cost per client reached. How did your strategy enhance the service that was delivered? Now, what are typical treatment or prevention intervention outcomes? And I'm making a clear distinction between these because this is where we often sort of find challenges in when economists are working with implementation science researchers. So intervention outcomes are typical public or global health interventions at the clinic or community level. They may include those on the right-hand side, typically cases prevented, cases treated, a health condition, an illness averted, a death averted. Hybrid implementation research often collect both. Now, when using costs in economic evaluations, costing or cost effectiveness, health economists want to look at a cost per health outcome averted. So cost of HIV prevented, a cost of AIDS treated, right? We use that because ultimately we want to get to a cost per disability adjusted life year averted or a cost per quality adjusted life year gained. These are economic evaluation metrics. Now, when you work with a health economist who's not so familiar with implementation science research, don't be surprised if we call your implementation outcome an intermediate outcome or an output. And the reason why we do this is it's very hard to get from those implementation outcomes that are distal, more distal from that case prevented or that case treated, right? If we don't have an effectiveness study, we can't directly look at illness or death averted. So time permitting, we can talk about those challenges of getting from an implementation outcome to a health outcome in the absence of measuring those direct changes. But this is a common challenge when costing implementation strategies. All right, so tying it all together, these are the basic steps in costing, right? You want to define the problem. You want to identify the activities and inputs, and you want to measure the quantity of resources and inputs used, and you want to value the resources and input used. You want to analyze total costs and combine those with outputs or to estimate unit costs. So I do think let me stop briefly for any questions. I do believe I have some time for the case study. I'm going to look to Russ to not, I think I've got 10 minutes maybe if I'm got that right. So any questions? Yeah. Any questions around some of the work some of the concepts I've presented before I go on? And I'd ask either Russ or Elena to flag those.
There was one question that came in. It says, sometimes I struggle to determine the right unit cost. For example, screening intervention, cost per person screen, cost per infection diagnosed, or for an NSP, cost per client per month or per year. What are the considerations when determining unit costs?
That's great. And you're setting me up actually for the case study. But really, this all starts with scoping your study. It all starts with a well-defined research objective for costing, right? And so it's one of the things I work most closely with teams. It's like, what exactly are you trying to get at? So typically what I think you want to be doing, if it's an implementation outcome or an effectiveness outcome, you want to be understanding the cost associated with that change in the implementation outcome or the change in the effectiveness outcome, right? So if you said, hey, I increased coverage, I increased reach. We used to only reach 1,000 clients. We now reach 2,000. What is the cost associated with that gain of 1,000 clients reached? Now, you may be interested in modeling the impact of that, especially in HIV/AIDS, where we have well-defined epidemiological and economic models, but it all starts with a well-defined objective. So that's a great question. Hopefully I'll answer that in the next set of questions. Anything else?
I think that's great. We have a few other questions coming in, but we can save them till the Q&A at the end, I think.
Okay, great. So hopefully this will help highlight that point and give some concrete examples of how this happens in practice. And of course, Dr. Glasgow will further do that. Now, I'm giving an example from a study I did with the Clinton Health Access Initiative back in 2013 called ARISE. It was assessing costs and effectiveness of expanding high-quality PMTCT services by community and facility strengthening in Mashonaland, Zimbabwe. I picked this because this is in 2013 before I even knew what implementation science research was. But looking back on that study, I realized that, in fact, it was an implementation science study. It was tweaking the delivery of services by strengthening supportive supervision and mentoring. And I'll get into that in a moment. So here are the steps in costing. Decide the scope of your evaluation. This is where you're going to determine what is that unit cost that you're really estimating. You're going to then map your intervention activities to cost categories. So that's the second step. And Dr. Glasgow is going to talk a lot about his experience in using process mapping and how he's done it. But when we talked, we both use very similar strategies to really understand what is being done and by whom. Then you will be designing or adapting data collection tools, and then you'll be analyzing and collecting those data and sharing results with stakeholders. So I want to just, this is a matrix I've developed years ago that I use with every single person I do a costing study with. So the first thing you have to do is really work closely with your stakeholders and identify the perspectives of the study. And I'll get to that in a moment. So this defines if the study objectives in our case of this ARISE project were to determine the effect of this intervention, right? So to increase access to WHO's PMTCT guidelines and also to create increased community access. If these were the study objectives, from that, you're going to say, what's that specific research question related to cost? And in our case, it was, what is the cost of providing more efficacious PMTCT regimes? Now, we were also interested in teasing out the cost of the implementation strategy. So the implementation strategy of this project was a facility level mentoring, supportive supervision that was provided by a team of rotating clinical mentors. Now, Clinton Health Access Initiative counselor and nurse mentors provided technical guidance on clinical and operational aspects, clinic flow, and organization. I'm not going to go through the detailed scoping exercise, but note that understanding the answers to each of these questions is critical for designing your study. And I call your attention to what will this data reveal and who's going to use this data, right? I mentioned the perspective. Perspective is critically important because it actually helps to determine which costs are in, financial or economic. It helps to determine your methods for data collection. It's not obvious to to people that are not familiar with costing, but perspective and objective are critically important to define early on. In the case of our project, this was a Canadian government-funded program, and the Canadian government actually wanted to know how whether or not they could avert a case of HIV for less than $500. And that was their specific goal, and we had to generate a number for the Canadian donor. But we argued that, okay, but the Ministry of Health or the Zimbabwe AIDS prevention program, they need to know what this is going to cost them. And so we were also interested in the government. And then, so we had a provider perspective in the study, that is the Zimbabwean AIDS prevention program. We also had to understand the government perspective, and we also had to understand the donor perspective. So whose perspective should you use? That depends on your objective, the cost, and it depends on who's using that data and results. Governments are often interested in costs incurred by society, how it affects all stakeholders. Private insurers may only be interested in the costs incurred by their company, so a payer, for instance. So a big part of costing, a lot of the work up front, is identifying and mapping activities and inputs to cost categories. And for those of us working in HIV/AIDS, here's an example for our study was looking at strengthening PMTCT. start with that cascade of care. There's lots of information out there that tells you what the steps are. Map those, understand what the actions and resources are, and help use that to identify your cost categories and your cost methods. So for our study, for the ARISE, looking at trying to strengthen demand and supply of these PMTCT services, we're very interested in the micro-planning, developing materials, training and mentoring, sensitization and awareness raising. We used a combination of activities that you see on the left-hand side, and also then input cost, health commodities, transport, equipment, personnel, etc. Now, you don't have to worry about these forms. You'll get the slides. You can sort of look at them. I wanted to give you sort of a snapshot of what the data collection forms look like. Often we develop these in Excel. In this case, we used a combination of financial expenditure data, and we also collected information through qualitative interviews from the bottom up, understanding what did you do, how many meetings, trying to understand the resource use at every stage of the project, to understand all costs. Specifically what I like to show, and we don't really have a lot of time for this, so I'm going to encourage you to come back and look at it. This is an example of what I like about this is an example of how we use that cascade of care to understand the time spent in activities by different types of primary healthcare providers, recognizing that there are many that provide services. In this case, a primary care counselor and a nurse, but you can see barely perhaps on the table, we mimicked the cascade of care, and we also pulled out time used for mentoring. That's the specific implementation strategy that helped to expand these services. So all cost templates need to be adapted to a particular costing analysis. Do not start from scratch if possible. Adapt as necessary. Reach out to any health economist you know for examples of Excel spreadsheets, and try working with a trained economist or health economist or someone with experience to help you adapt those forms. Very quickly, the cost metrics, you won't be surprised to see these are total intervention costs. We exclude research costs. We can talk about that. We were interested in the donor's financial investment in this case, which was the Canadians, and the total economic costs. So the donor, just financial costs, the government was the ZAP, and the NGO was CHI. We wanted to understand the cost per pregnant woman screened, cost per HIV positive woman treated, and infant treated, and cost profiles. This table is very busy, but I want to point out something. Notice how we're able to have all the cost categories on the left-hand side that I shared with you, right? And then we could look at the cost by the Canadian government's upfront financial investment, the total annual frontline financial cost, and economic. And then in the same table, we could highlight, by understanding the number of beneficiaries reached, we could understand these costs per beneficiary reached, right? So this could be considered perhaps penetration. And again, presentation is important. I won't go into detail, but using graphs is an easy way to convey how costs are allocated by activity or by timing. And in this case, we look at the cost shares for CETA's costs, for just the annual financial costs. And when you look at those annual economic costs, you can see they're quite a bit higher, right? So what the donor puts in could be $800,000. The total cost of the program is more like somewhere between $1 million or 1.2 million, right? So this is when you take into consideration all resources used, the cost of the program definitely changes. And an example of how you can look at cost by timing, i.e. recurrent costs or startup costs. And this is also important information. So very fast, that's the primer. We're going to keep talking about some of these issues in the next presentation, but why don't we, if time permits, take some questions and have some discussion. And I think both Dr. Glasgow and I can respond to questions at this point. Elena, if you can help, I'm going to
yes.
stop sharing.
Great. So I actually think I know the questions that have come in so far actually kind of tie into some things that Russ is going to be talking about. So maybe we can actually transition to Russ and then take questions at the end. Is that okay?
Works for me.
All right. Sounds good. Over to you, Russ.
Thank you. Can you hear me now?
Yes.
Okay. Sorry, a few technical difficulties. Hello, everybody. Great to be with you. And thank you, Carol, for that great overview. I'm going to follow up on this as part of our partnership and drill down much more narrowly to talk about a specific pragmatic approach to implementation costing. And one of our goals here that I'd like to make explicit, it's implicit, is we'd like to demystify some of this and make it a bit less intimidating for you than I know it is for many people here. I do want to just briefly acknowledge my great colleagues that were real helpful in both collaborating in general, but also putting this talk together there. And I believe both Jack Cronin and Andy Eisman are on the webinar, and invite them to jump in, and they can, when I mess something up, they can maybe correct that. What I'm going to do in a very rapid fashion, so we have enough time to discuss and get your questions and comments here, is just briefly to talk about, from an implementation science perspective, why is costing so important, some of the key issues, and then the heart of what I want to talk about is to come back to this issue of perspective that Carol set up nicely. We can't emphasize this enough. Then I'm going to talk about a specific approach that we use, a practical approach, certainly not the only one, but of process mapping, and then based on the process map, activity-based costing. And then I want to share some examples and talk a fair amount about presenting your results once you have that to different audiences. Again, I'll go rapid fire so we have enough time for your questions and comments here.
Russ, sorry, not to interrupt you, but it looks like you're not actually in full slideshow view.
Thank you so much. I just recognized that myself. How about this?
That looks great. Perfect.
All right. Thanks, Elena. Appreciate it. First, let me give you just a little bit of background on myself. I think it's important for context, and so you know where I'm coming from. First thing is, as Kenny mentioned, I'm a longtime implementation science researcher. In fact, I was doing this before we called it that. Very important, though, I am not a health economist. I want to be real clear about that because I probably will do some things that are dangerous and have not had any formal training. I have been really fortunate to have collaborated with a number of great economists in my career. I have been, however, a pretty major advocate within the field for the importance of costing and more generally economic evaluation. And our group has done some reviews of implementation science in different areas and documented that, at least until recently, fortunately this has changed, but like reporting on cost is within one of the things least often reported. And Carol noted that cost is one of the key things in the Proctor model of implementation outcomes. It's also under our REAIM method, and I'd be glad to talk about this later if others would like to, that we've explicitly added it under the category of implementation outcomes. Most relevant for today is I've been fortunate to be part of a consortium we'll talk about later for the last couple years, brought together an informal group supported by both the VA and the National Cancer Institute to really bring together economists and implementation scientists to see how we can collaborate, to talk about some of our cultural differences and our terminology issues. And this group has written a number of papers that I'll be referring to throughout my talk. Okay, so first of all, why is this important, and why really should you do costing? One of the key things is that, as it says here, that's often the key, one of the first questions you'll get from an adopting setting. Let's say you're wonderfully successful at your intervention and now you want to disseminate it. often you can get that. And if you don't have an answer to that, often functionally the conversation's over with. I also want to mention, I'll give you some examples of this, that usually what potential adopters want to know, though, is not just what did it cost you in your study that you did, but what would it cost them in their setting to implement this. Most important, what I have in bold here, is that cost is very often usually a key determinant of many of our implementation outcomes, whether something will be adopted, how successful the implementation can be, adaptations I'll come back to, reason for adaptations, and then especially these last two of sustainment and dissemination. I feel it's so critical to that. And I want to start with, or not start, but now as I launch into 6 specific issues, I want you to think about this question and then some other issues. You can make a note to yourself to come back when we have the general discussion. But to me, the central question I want to propose is, what will it take to replicate this effort, this program, both the intervention and the implementation strategies in your setting? And then here's some of the sub-issues that we can come back to. What I'm going to do now is, in a very whirlwind fashion, about 2 minutes each, go through these issues here of getting your perspective right, estimating at multiple times. We'll talk about when there are particular times to look at costing. As I said before, this specific, kind of more narrow, but we find really useful approach of process mapping and activity-based costing. We'll talk about some of the methods and your choices available for costing and the cost of assessing cost with those. Reporting it, I do want to talk about for reporting to different decision makers. And then finally, an issue that we call replication cost here. Much of what I have to say is drawn by and presented probably in a more clear fashion, detailed in a recent guidebook that we've developed. And you can see the names there of, again, a nice consortium, about half economist and half implementation scientist. The purpose of this guidebook that we have is to help, especially implementation science and their team, to develop and cost this. We do emphasize, again, a subset of microcosting that we call activity-based costing, and we've attempted to provide a lot of examples, templates, and fillable forms here. This is the table of contents, but I do want to emphasize that in addition to this introduction, we hope that one of the things is that this can prepare you for consultations with economists. So you'll kind of know what the key issues are to come in, have done a little prep work, and be ready for those consultations. I know there was a question in the chat about, well, when do you need an economist? And we'll come back to that. So quick dive into these issues now. And again, as I indicated there, one of both of our take-home points is how critical this perspective or perspectives is. And I think you need to understand this. As you can see on the right from the social ecologic model, going down there are a whole lot. And Carol mentioned even some other ones, but all the way from the perspective of the individual recipient, especially to the team. And I focus a lot here on either the implementation team or the organization, the setting, the clinic, the workplace that's doing this. But there are other critical, important issues too. I'm fond of saying that cost are not cost are not cost. Carol outlined nicely some of these costs, fixed versus variable, and other issues there. But I also find pragmatically that talking with different decision makers, some of them are very interested in, well, what's it going to cost to launch this, to set up? Others on the ongoing cost, and even others often in, well, what are the sustainment costs after this over, maintenance on a long-term basis? So please remember, start out early on, define, have a good engagement with these decision makers and understand what's important to them. And that means what you're going to want to report back to those on. Another take-home message is to assess costing early, maybe even before you start implementing, and as often as is pragmatically feasible. I emphasized at the top here the planning and engagement stage. And I think for implementation science, this is an important and understudied issue, is that to be successful, we often need very substantial and ongoing engagement before we start doing that. That is part of what we want to think about and when other people want to replicate it. So it's important to cost that out, as well as when you're actually delivering the program. We can come back to this later, but I think it's possible and maybe advisable to do some level of modeling before of what the costs are during the planning stage. And this can be all the way from a very simple, what we call back of the envelope, to very sophisticated predicting modeling. If possible, I like to recommend doing costing 3 times, at minimum, like 2 times. I don't think sometime early or mid-implementation, and then other late where there's more of a steady state or people more experienced at doing that. We will also talk here about being pragmatic, because we know for many of you, you may not have really adequate funds for a health economist, and there is burden both on your implementers and your research staff. So I'll talk some about that. Again, we use this method called process mapping and activity-based costing that I'm going to quickly run through and give you some examples. But the idea of process mapping is that this is a visual representation of the various steps or activities. And I will also say parenthetically, we use process mapping not only for costing, but for understanding the intervention qualitatively and contextually, and also for doing interviews about adaptations, which I think is an important issue in the field. I will skip over and try and go a little more quickly here. But the initial step that we use for developing a process map is first just to do kind of a list like this about thinking about when in the process does this occur early, what is the specific activity, and then who does this and what resources are required. Is it front desk staff here? Is it medical assistants that does that? Is it a provider or a clinician? We then use that essentially table to turn that into a diagram. And I know you can't see all the details here, but I want to emphasize 2 things. One of them is the temporal aspect here of, is it pre-implementation or planning? Is it during implementation or is it during the sustainment or maintenance phase? And that these rows are what we call swim lanes. But the swim lanes talks about, well, which type of staff? And I'll come back to why that's important. And in this particular example, we had research staff, we had providers or clinician, and then clinical support staff there. Importantly, some of you might be familiar with a related approach that is not process mapping, but related, that implementation science can often relate to a little more intuitively, and that's called COINS, or Cost of Implementation Strategies, by Lisa Saldana and colleagues. Again, it has this notion of not only phases, but they divide it into 8 different stages that apply. And again, I would note maybe with adaptation there, as do most all of these. An issue of how are you going to cost? Now we talked about maybe what do you want to cost, but how do you do this pragmatically? There are many different, I'm sure we'll want to come back to this, but many different methods. And again, the answer is it depends. If possible, I think the gold standard from my perspective, being a behavioral scientist, would be observation. If you can actually get out there, do an objective assessment, but pragmatically, that's often not possible, at least other than doing spot checks. So other alternatives that are frequently used here, sometimes in combination, are activity logs, which again provide a lot of specific information, and over time, if you can get people to fill those out on a regular basis. Other things like targeted questionnaires, and in our experience, particularly if you have this to start doing one of these two, the logs or questionnaires, and then follow up with an informant interview can be real helpful. Very quickly, I'm going to show you a couple of examples that we have templates available in this costing guidebook that's available online. And as Carol mentioned, this is simply just a spreadsheet or an Excel file. It's not rocket science, but sometimes people find it helpful to have an example and a starting point there. But you can see we're talking about who does what, what's their strategies for different activities, what does it cost. Then we will roll this up, and I want to make another important point here, is we have the time cost that's involved here with and the personnel cost. And then this notion of both training, and I should have added the engagement or planning costs there, but we also have other costs here. So usually, in my experience, often the time to deliver is the key cost, but there often are other, and sometimes they're substantial, like initial cost here, like equipment and other resource cost here too. So costing the activity is not everything, though in our experience, it's most of it. So I'm going to turn it over to Elena here. I'd like to take a glance at the clock here and see if we have time to pause for one or two questions, or if we should go on. Just for reference, we're about 2/3 of the way through my talk, but I want to at least catch my breath here and see if there are one or maybe two quick questions if we have time, Elena.
Sure. Yeah, I think there's actually one question that just came in that might be good at this point during the presentation. So the question is, can one use activity-based costing maps and decision trees, or is that somewhat duplicative? So both activity-based costing maps and decision trees.
I'll give a quick shot at it, and then we'll see. Carol might want to answer too. And unfortunately, the answer is my usual one about any complex issue, it depends. I think in our case, often we'll use kind of a decision tree to actually create or use it with the process mapping there in the same way. I think those are highly related activities. And then based on that, do the actual costing after we understand kind of the flow or the sequence of who does what. But Carol, you might want to elaborate or add some other points or correct me.
Yeah, I think actually activity-based costing is, I think, different than the decision tree. The decision tree is kind of mapping out the probabilities, and it doesn't capture all the resources used. So I would say activity-based costing maps, using your program theory of change is useful. Using, in some fields, we have something called an impact, a program impact pathway. But I think it's better to go back to your conceptual framework and description of the intervention. A decision tree is a way of organizing your actions as well as your probabilities and costs. But I think you want to focus on the process mapping that Russ has been describing. Over.
Great,
So,
thank you both. And yeah, I think we can go on, and we'll have some other great questions for the Q&A at the end.
Okay, great. So again, just a couple key issues, and then I'll wrap up and leave you with some thoughts about both take home or summary, and also some maybe things for the future of costing and implementation science. So this issue number 5 that I think is really important, because it's not just enough to do a really competent job of knowing your cost and assessing them, but also you need to communicate this. I probably can't emphasize this enough. It's important to think about your audience here. Who are the decision makers you're talking about that you're hoping will pick this up, either continue or adopt it? And then also reviewers, for many of us that want to publish, to think about those. And you probably want to emphasize different things. I personally feel it's helpful because people are different types of learners, understand to have both some really visual examples, some graphic examples, and also some tables or approach there. I also personally feel it's important to show the cost of different roles, different types of folks, and I'll talk specifically why that's important later when we discuss issues like task shifting and what we call replication analysis, and then also by the phase of the project. So very quickly, I'll mention just the left-hand side here, which I'm not going to focus on today, but for publishing, there's a number of issues that are similar, but somewhat different than if you want to talk with local decision makers in the right-hand columns. I would really refer you here. There's a great reference that Carol and her colleagues have developed. The URL is at the bottom there, and we'll make it available. And also, if you're doing other more comprehensive types of analysis, there's a standard guideline, abbreviated CHEERS there. But for today, I want to focus on some recommendations here when you talk with local decision makers. First of all, keep it brief. I think if you, less is better in sometimes, but you can have some things to follow up. This use of clear figures and tables, I think, is important. And then to be ready to talk about and maybe even have some examples of things that might change the conclusions that you have there. So again, a very simple type of table. This was like a physical activity program intervention that broke it out by the cost of the health educator, the instructor, and then I think this was done in a day school, actually, through what were the staff, and then again, the different phases that were involved there. And again, this is a good example of tailoring at that note. This isn't specifically called out, as I talked about before, of like pre-implementation, implementation, and valuation, but kind of these were the phases of that particular study. This is a slightly busy example, a little more complicated than I'd recommend, but I like a number of things about it, as well as this general article that's referenced at the bottom there for activity-based costing. This one does use the phases, if you will here, the 3 phases. Again, they're not always 3 phases, but what I like about it is the color coding, and it talks about here the time that's involved over the course of the project by different roles. The blue here is a practice facilitator. The orange is a site administrator there. The gray are different clinicians that are involved. And then the orange, I guess that's yellow, is the consultant that's involved, their time there. In fact, last issue I want to talk about before summing up is one that I learned from my economist colleague, Deb Ritzwaller, and I think is really important and returns to the kind of core issue again, and that is of understanding both sustainment cost if you do things differently than you have during the original project, and then also replication cost, we call it. And a quick example here is that, let's say you did an original study that you did in a community health center, an FQHC here. You do this with a particular set of staffing and resources that are available. And then let's say some other setting, just for example, VA wants to use this as a different set of resources. And in particular, in this example, they may have a much more sophisticated electronic health record that they use for a number of activities. Note here that in terms of who does different activities that are listed, in the original study, this was done by front desk staff. This replication study, they have a lot of medical assistants that did that. In particular, most of the training or counseling was done by behavioral health staff here in this setting. Over here, a large amount of that was automated. So the point is not the details here, but there are going to be different resources, probably different process maps, different people involved here. And so we feel this is important to really be able to answer this question. What will it cost in a different type of setting to estimate that? And we have developed what we call a replication cost calculator here. So in summary, these are the 6 issues that I feel, pragmatic issues that I think are important here. And I'll just emphasize this notion of process mapping, activity-based costing, and then deciding what can you do with issues of burden and your own cost and resources to assess these, and then reporting the cost out. A couple last slides to summarize the key points of what I have to say is, I think if it's available and affordable, it's always good to consult with an economist. I personally feel that in some cases, if you're just doing the basic time-based activity costing, you, with some help, set up guidance and references, your team can do at least 90% of that on your own. However, again, it's always good to consult. And if you're doing something more sophisticated, looking more downstream, looking, as Carol talked about, want to talk about cost effectiveness or cost utility, that sort of thing, I think it's probably essential that you go to an economist. But I think you can go much more informed and make that a much more efficient process. And I'll leave this last point for later, other than just to acknowledge that we're talking about the importance of cost issues, but cost is just one of the important implementation outcomes. For the future, I think some of the exciting issues, why I'm very pumped up about costing, is to look at issues like I've outlined briefly here. For example, like what outcomes are both implementation outcomes and effectiveness outcomes or service outcomes are most impacted by cost. Looking at this issue, this gets the replication cost of the same program in different settings, and especially with different levels of facilitation. Those of you that do global health know a lot more than I do, but I think even for domestic programs, looking at the impact of task shifting or those of people in different roles involved in doing implementation or delivery. And then also in the future, looking at costing out different adaptations, which of course is a hot area. So I'm going to return, and as I open it up for costs now, to what I called the central pragmatic question about what will it cost to replicate this effort. And these are some of the issues, but let's maybe start with your questions that you have there. And both Carol and I are all ears and look forward to talking with you about this.
Great. So we do have a few questions that have already come in, and invite folks on the line to continue entering your questions in the chat for the Q&A. Maybe just to start, we have, so Russ, you already talked a little bit about this question, but we have a great question, which is what level of expertise in finances do you recommend for a pilot implementation of a multi-level complex intervention in one healthcare system? What other types of resources for learning do you suggest? And do you recommend having a consultant manage this piece? And if so, how does one identify a collaborator? So lots of great kind of sub questions in there as well, but would love to hear from you again about this, Russ, and also Carol's perspective.
Yeah, that's great. Well, I'll start off. The first one, when you talked about like the financial consultant, as Carol talked about, and she can go back and clarify again, that's a bit different than the type of costing that I've been involved. There's some slightly different issues. I'll let her cover that there. Again, I guess my line is if and when you can, and if you can afford it, it's always helpful to have an economist consultant available, or sometimes it's almost more of an accounting issue. Being realistic, economists are not always available. In my experience, a lot of economists aren't unfortunately into this type of thing. They'd rather do work on other issues, including, big data and secondary data and that sort of thing. And let's face it, there is a cost to economists too. And unfortunately, from my perspective, often this isn't built into a grant. So it's always hard to do something after the fact. But I do think if you have some things like the resources Carol has shared here, in the references we have. I hope in this costing guidebook that we've done, there are some things that can help you do a fair amount of that on your own, at a minimum, to really understand the issues here. But I'll turn it over to Carol now, particularly because you framed it as kind of the financial issues.
Thanks. So actually, it's again, a little bit of it is terminology. So a couple of things. I think I'm sharing my screen. We have looked, and this is for global health costing, so these may not be relevant costs for public health in the US, but there are two ways to do a study: standalone, which it often is done, and I don't recommend it, or integrating it onto your ongoing evaluation. For domestic studies, this is often the case. So you asked the question about what kind of specialist do you need? I found that if I agree, if it's something that time motion observation, things that qualitative researchers can do, no reason not to work with a qualitative researcher on this. In my work, I've often been able to work very well with non-economists, but I would say that it does help to understand these concepts, and that it isn't easy just to take someone that's a data clerk to help you fill in information, or often monitoring and evaluation people, not even economists, aren't particularly interested. So I think one of the methods we've used is trying to find someone at your organization who might be a technical expert with experience in costing or economics that works with a graduate student interested in learning this. So I hope that's helpful. I do, over the years, I really am advocating that you try to work with someone with experience in this area, and that they are a health economist or have experience in that. Regarding level of expertise in finances, to use financial expenditure data, you don't have to have any expertise in finances. It's a source of information. So when I talk about costing, micro costing is much of what we've been focused on, going to look at activities, quantity, input. But sometimes, like I said, a lot of these projects are funded externally. You know what you spent, and it's a matter of adjusting it to make it more real life, or to what if you replaced a university PhD student with a local provider, right? So this is something you can, these interesting topics that Russ mentioned at the end, like are possible to do through scenario analysis or sensitivity analysis. How do you identify a collaborator? I think you just, whatever your organization is, look inside your organization, look in all the various departments. You'd be surprised, there are more people out there that have an interest and experience in doing this. Reach out to UW, reach out to UCLA, or University of Colorado. Over.
Yeah, I think good one. That's part of the role of groups and, your pub leaders, Allison and Kenny and things, is to help you navigate, or other ones to find that out. And unfortunately, in my experience, it's not always available locally. Again, as Carol said, I'd start there, but usually, like the economists I work with are so oversubscribed, it's really challenging or difficult, but often they can help you. So I would say, just be, I think, persistent at doing that. If you can go there organized, rather than just come in and totally kind of throw everything without done any homework or trying to understand it on your own, that's going to make it more difficult. And if it's okay, Elena, this cued off another question, different but related to me, but it's this issue about what costs are important, and it bears on this issue of replication costs that I'm obsessed with. And that's the issue that Carol mentioned briefly, but we haven't covered in detail. But it's about costing, or separating, distinguishing research cost, from cost of delivering a program. And let me start out that, and then again invite Carol to jump in here. But from our experience with the examples, it is important to take out, because bottom line is, usually we want to talk about, after you've tested this program, evaluated it, and if it works, you want others to take it on. Certain activities they won't need to do in other settings. One of the key ones that I always think about there is like IRB issues and consent issues. Often, if that's part of regular practice, you don't need to do that. Other research costs that are frequently there are things like assessment. And that one's a little tricky. But in terms of assessment, what the guidance I like to do is, if this assessment is really part of your program or your intervention, for example, if it's kind of like quality control or evaluation, where you're doing assessment and getting feedback, then yes, you want to cost that. If it's a more intensive, comprehensive thing that you're doing for understanding or publication, then I wouldn't cost that if that wouldn't be part of what you're doing there. Another one that again is a little tricky, but I think you can parse it out, is the cost of recruitment or promotion there. I think often I see people leave that out, and I think that's a mistake, because any program is going to need to do some level of promotion or advertising. Now, again, it probably will be different than you would do in your research study. So again, that's maybe a replication cost there, and you might need to do it all. You certainly wouldn't do it in the same way in an existing program. Could be less or more. I think often it can be less, but I think it's a mistake to leave it out totally. So with that, I just wanted to kick it off from my pragmatic thing, but I'm sure Carol's had a lot more experience than I have in this, and she may want to jump in.
Yeah, well, I'll share some experiences. I think you've covered everything very nicely. I have a couple of rules of thumb, and they sometimes work and they sometimes don't with the team, with the implementation research team. So the first one is I like to think about my basic rule of thumb is, was this an essential activity for the outcome you achieved? Now, that's hard to know because often I've found lately that I've been asked to generate my cost estimates before we have the effectiveness estimates in a study. But assuming that you will have reached your, you will have met your hypotheses, that you have reduced, that you have increased coverage of HIV services, that you have reduced depression-free days, that you have, whatever your implementation or intervention outcomes are, was that activity essential for the design, installation, implementation, and maintenance of that program? Now, to me, that seems really obvious, but sometimes it's not obvious to the teams. So that's one thing. The next one, I found that in practice, when I'm working with an implementation research team at the University of Washington, it's very hard for them to distinguish implementation of the action from the implementation research. So again, trying to parse out what is evaluative for effectiveness or impact, or for either health or implementation outcomes, from the actual, we often have our researchers involved in designing the intervention. And that's why it gets really hard at a personal level for people to think about, wait, how do I tease out research from implementation? I'm doing it all together. So in practice, it's harder than it looks, but yes, you don't want to include those unless you want to cost out the research, but I don't know why you necessarily want to do that. And in terms of strategies regarding staff time, I basically create a spreadsheet, and I put in the total time that was allocated. I mean, often, again, these are funded by NIH. So for your PI and your lead, your co-investigators, list them all, indicate their FTE, and interview them. Sit down and work with them and say, what percentage of your time do you think was for the design of the intervention, and what was for the design of the evaluation? And you just have to really work with them to kind of help them understand those concepts and get them to give you an allocation. Sometimes it's 50-50, and assumptions are okay. Economists love assumptions. So that works too.
Thanks so much. I think Russ is having a connection issue, so we'll get him back online as soon as possible. But Carol, we have a bunch of other wonderful questions coming in. So let's move to this one. How do you generate a single strategy and design for multiple stakeholders with different cost focuses? So
yeah, that's a great question. When you receive the slides, if you can go back to the case study that we gave, that was exactly what happened to us. We had a donor that was interested in understanding the cost per HIV case averted. That was the Canadian Aid Agency. We had governments that wanted to understand what were the costs to them. And then there were researchers that wanted to use the cost in economic evaluation. That's three perspectives, three stakeholders, three perspectives. So it just requires explicitly articulating who your stakeholders are, what the research question of interest is, and then designing the analysis so you can tease out those costs. And it sounds complicated, but it's a little bit easier to do than you might expect. Why? Because the sources of funding are coming from different places, right? That we know what the donor expenses are. Those are the funds that you're using to run the project. And you have to tease those out to what are called those kind of frontline expenses, what's really being spent at the community level, at the health center, or at the school, wherever your service delivery platform is. For the government, you're micro costing it. So you're only asking questions very specific to what their resource use is for that. So it is possible to do. It's all in the upfront design and carefully using the scoping tool. Happy to share materials with folks later. I will drop a guidance document that's related to multisectoral nutrition approaches, but might be very helpful for how to set up your study. I did want to, I saw a question I wanted to answer about the hybrid studies, the best time to incorporate costing, if I could address that.
Yes, that was actually the next one I was going to ask, so feel free.
Really, there's a tendency to think about costing as something that happens at the end. Incorporate it from the beginning. We always call ourselves the aim 3, we feel a little relegated to that third aim. If you want to collect data efficiently, if you want to do process mapping, if you want to take advantage of all other sort of formative research and early on preparation, add your costing in at the beginning of the study. In that way, as Russ said, you want to collect data at 3 points in time. At the beginning, capture all those startup costs. I remember I was working on an implementation study that had 1 year prep in the design of the study, right? 1 year. Half of that was to the evaluation, but half was the actual design of the study. And so I was a part of that. So I know we spent a year doing this, right? So I had that experience. I understood how the materials were being developed and when the training activities were being implemented. So catch that startup period. And so integrate it straight away. Don't wait till you're 2 or 3. That'll be too long. Okay, I'll let you, Elena, pick the next question.
All right, great. So many great questions coming in. Another one is, would you please comment on how to streamline data collection to reduce burden of documenting every task and their related costs?
Okay, if you can put that in let me just make sure I'm understanding that. Yeah, put it in there. Would you please? Yeah, so I think I might have mentioned that. Yeah, you don't have to document every task. So that's the good news. You have to generally understand the activities. You really don't have to document every task. You really do have to understand what the intent was, especially for implementation science, focusing on fidelity, right? How was this strategy intended to be implemented, and what are the essential steps for that? The way to streamline it is what I just said. Think about it early on. If you are doing a process evaluation, if you are creating, I know that many projects are actually collecting data at 3, 6 weeks, 9 weeks, 3 months, 6 months, 9 months. Incorporate questions around time spent in the activity and resources used. It isn't that hard. So again, early planning and leveraging existing questionnaires. And then you're really talking about very specific cost data collection at 3 specific points in time, maybe 3 1 to 2 week periods at the beginning, middle, and end of the study. And that's the collection part. The analysis is kind of ongoing. Hope that's helpful.
Great. This might be a quicker question. If you purchase a large capital item for a study, but don't use it to its maximum capacity and no one else uses it either, can you allocate the proportion of the cost to your intervention that you use, or should you factor it into the entire cost?
Yeah, and so I did answer that, and I actually shared an Excel file, but I'll answer that verbally.
For everyone,
Yes,
yeah.
you want to be so when you in economic analysis, and even when you're doing financial or economic costs, we don't include that upfront investment into the analysis. We include the annualized depreciation costs. So there are different ways to calculate that, whether it's a financial analysis or an economic. A good reference for that is Walker and Kumaranaki, allowing for differential timing and costing. That will walk you through how to do it. And then to the question of, well, you bought this large capital item, we call that a shared program cost. If only 10% is used for your project, allocate 10%. And then there are different allocation methods for shared resources, and that's what that Excel file is, with some references.
Great, thank you. I see two more questions so far. The first is, can you comment on success in applying for grants for secondary cost analyses? So this person mentioned we collected a lot of data, time, motion, monitoring, delivery, but need funds to support the effort to analyze.
I can't really comment on that. I'm sure it, yes, we tried to get an NIH grant to do that, and we didn't get it. It was funded by the Bill and Melinda Gates Foundation. So NIH doesn't seem to be funding those kinds of things. Yeah.
Thank you. All right, and I think we're getting one more question in the chat now, but the next question is, I was curious to learn how often studies distinguish between the costs associated with the evidence-based interventions and the costs associated with putting them into action, implementation, or implementation strategies. Sometimes it seems like they're all mixed up and hard to separate.
Oh yeah, that's a good question. That's a great question. That could take another half hour.
Yeah.
Let me just tell you my observations. In global health, which I've predominantly worked in, but recently been doing behavioral health in the US. In global health, it's nearly impossible to implement an intervention without focusing on implementation. We're working in resource-constrained settings. Human resources are maybe not skilled up. So in the past, we packaged both intervention and implementation together, and that's how we costed it. When I started working with behavioral scientists, I realized that they said, well, all right, I've got this evidence-based practice. All right, that's not what I'm costing. I'm costing this very specific implementation strategy, whether or not I have internal or external facilitation to introduce this and scale it in clinics. And so again, in global health, we are separating implementation a little bit more from interventions. But again, this is harder to do when you haven't demonstrated that the intervention is effective in that setting. It requires a lot of conversation with your team. I recently worked on a proposal here at UW, and we had that very conversation. What are we costing exactly, the intervention or the implementation strategy? So again, it's just a matter of, again, back to that scoping exercise. What exactly are you showing? If you're going to measure health outcomes that are a result of the intervention and the implementation strategy, then you have to cost them both. Hope that's helpful.
Great, thank you. I think we have time for this final question here. The question is, how do you respond to reviewers who say that AIM 3 on cost is dependent on AIM 1 evaluation?
Quite honestly, as I mentioned, I kind of alluded to the fact that often I'm asked to publish a paper on cost before we know whether something works or not. A couple of things. When we write our NIH grant in AIM 3, there is a chance that it may not be effective. But what I like to put, the kind of language I like to put in is, we know something like this, we may tweak it. We want to understand the resource use and the efficiency in this intervention, whether it works or not. because we're still working in this field and we still have a shortage of information on the cost of these kinds of interventions we're doing. So there's a rationale why you might want to understand the cost of things, whether they work or not. But I'm actually in agreement. I mean, and I may be that very reviewer, like, well, does this work or doesn't it? So it will depend on a couple of things. Was there evidence that these kinds of interventions worked? If you know that PMTCT is effective, if you know that HIV, certain home-based care is effective, certain strategies have been demonstrated time and time again to be effective, I think it's okay to publish your cost paper and use secondary data to justify it. We have got a lot of papers published that precede the impact evaluation. So, you're just going to have to kind of figure out what makes sense. But honestly, I think my preference is costs come with or after impact evaluations.
Great. Thank you so much, Carol. We're getting a few thank yous in the chat to you and Russ for this very informative webinar. For attendees on the line, we will be sending out an evaluation and the recording and slides from the session. And we look forward to seeing you at our upcoming methods workshops, both for the UCLA Implementation Science Hub and the University of Washington RAISE Implementation Science Hub. So thank you all again. And thanks to you, Carol and Russ. Have a good day, everyone.
Thank you so much.